So Ken, thank you very much for your welcome. And I can't remember who I am most of the time. And particularly at work, I use a different name at work, so that's the alter ego that I have. But I'm known to the church as Julia Marsh, so I'm quite happy to be Julia Marsh here today. So what I'm going to do today is to tell you a little bit about myself, just a tiny bit, for those who don't know already, and then tell you a bit about childhood cancer and its treatment and the care of our patients and families. And then I'm just going to reflect in the last little bit about the sense in which the work that I do involves doing God's work, as in the title. And I am very conscious that many people here may have been touched by cancer either themselves or in a loved one. So, sometimes, even though I'm not going to be talking about anything terribly difficult today, it can be a bit tricky. So if you find anything that's difficult today, please do speak to myself or Ken or one of the other senior people here afterwards. Just being conscious of that. So first, a little bit about me, just to set the scene, really. So as Ken said, William, my husband, and myself have been here as members of the church really for a long time now, since 1994, and we've had 3 children that have grown up through the church, and we've been involved in various ways in the church. For me, most recently, I was part of the PCC and the senior leadership team 2 or 3 years ago, and then I'm part of the Alpha team, although I'm not actually helping with the current Alpha course. Just by way of background, William and I met when we were both studying together at Christ's College in Cambridge. I was studying medicine and William was studying engineering, but it was at Christ where I became a Christian. I arrived at Christ with a bit of family crisis going on. My parents were in the middle of a really messy divorce, and I joined in an inquirers group, if you like, and became a Christian at the end of my first term. And that's been a really major influence on the whole of my life, but including my career. And I hope that will come out a little bit as we speak today. After I graduated in medicine, I trained as a paediatrician. I then specialised in children's cancer. And then I became a consultant paediatric oncologist at Great Ormond Street Hospital, where I was for 10 years, from 1999 to 2010. And then in 2010, I left Great Ormond Street Hospital. I came to the Royal Marsden here in Sutton, so just up the road. And one of my big tasks then was to build up the brand new service for young adults with cancer, the 16 to 24-year-olds, as well as working in children's cancer. And I then ran the unit as head of unit for 6 years, from 2012 to 2018. And as Ken mentioned, I now have some more senior positions, both regionally and nationally. So what is cancer? Well, I just thought it might be interesting to start here. Perhaps you ask, well, why am I asking that question? But if you look at the dictionary, it says it's a disease caused by an uncontrolled division of abnormal cells in the body. And there's a couple of examples of rhabdomyosarcoma there, which is the kind of tumour that I work on. You're probably aware that the cells in the body, the building blocks of our body, normally have strict checks on their cell division. And when those checks get disrupted, cells can start dividing in an uncontrolled way, giving rise to either a lumpy growth, or if it's in the blood, to leukemia. And that can occur pretty much in any part of the body. And depending on where the cancer starts, you get different kinds of cancers with different kinds of names and belonging to different families. I don't want to be too technical today, but we do understand much more about what's driving cancer at the cellular level and also in the genetic material underneath that. And we're beginning to be able to exploit our understanding for therapeutic gains. And we'll speak a little bit about that as I go through. So that's the science. But if you ask, what does it mean to have cancer? That's a whole different question, isn't it? What does it mean to have cancer? If you ask someone with cancer, what's it like? They probably won't discuss the science. They'll probably say, what a massive disruption, insult, shock it is to them. A bit like an earthquake shown here, where the ground just opens up and all the firm ground is taken away. Or it could be described as a storm or a massive blow. And it's often unexpected, it's shocking, it's devastating, and it turns people's lives upside down. It's an emotional roller coaster. Patients have to go through difficult treatments often, and there may be nasty side effects. And when you then put that into the context of children's cancer, which is what I'm focusing on today, and I'm not really going to talk so much about the young adults, I'm going to talk more about the children. You've got all those things for the parents, You've got the disruption to family life, maybe looking after other children while you're trying to get your sick child to the hospital. Sometimes one of the parents has to stop working for a while to see their child through treatment. It's expensive. It costs several £100s additional every month to manage family finances when you've got a child with cancer because of travel, because of food when you're at the hospital, all those kinds of things. And for the child, they'll miss their friends, they'll maybe be off school, they may feel unwell, they're separated from all the things that they normally do, and it's a really difficult experience. So there's kind of two things. There's the science, and then there's the turmoil, if you like. Now, just a few facts about childhood cancer. I'm not going to dazzle you with facts at all, but this is my one slide with facts, and I'm sorry if it's a little bit small, but I'll talk to it. But the facts are that in children under the age of 15, there are just over 1,800 new cases of cancer in the UK every year. And the blue blobs there just show you which are the most common kinds of cancer. So leukemia is the commonest group of cancers, and that there are two kinds. Acute lymphoblastic leukemia is the commoner one, but we also see acute myeloid leukemia. The next biggest group is the brain and spinal tumours. And then lymphomas, soft tissue sarcoma is next down the list. That's the one that I work on. And then we've got others like neuroblastoma, kidney tumours, bone tumours, and so it goes on. That doesn't matter, the details don't matter, but the point is that these are very different from the kinds of cancers that you get in adults. They're rather specific to the childhood age group. Overall, children's cancer is a success story. You'll see there, if you can read it, that the 5-year survival for children with cancer is now running at about 84%. So the majority of patients will survive their cancer. That's fantastic, and it's better than it is in adults. But for individual patients, we know from the outset some have a very good chance of being cured, and for others it's still very poor. And some of the patients I deal with, particularly the young adults with sarcomas that have spread around the body when they first come to us, we may know that their chance of survival is perhaps even less than 10% from the get-go. Why does childhood cancer happen? Well, we don't always know. In fact, we usually don't know. In adults, our adult bodies accumulate genetic changes through life, just through the process of cell division and, if you like, mistakes being made, but things like tobacco, alcohol, sun exposure, obesity, all those things kind of, if you like, speed up the process of genetic change in cells, which can then drive adult cancers. In children, they don't tend to have so many genetic changes in their cancer to drive them. And so we don't always know, what's the trigger, why has that happened? Occasionally, there'll be something that the child has inherited from a parent, like a predisposition gene, and that child will be at increased risk of cancer. But that's probably less than 20% of children. And for the majority, we don't really know what triggers it in that individual child. Acute lymphoblastic leukemia, that's our commonest childhood cancer, seems to start off even in fetal life. And you can recognize some features of the pre-leukemia at the time of birth, but then it takes something else to trigger the actual development of leukemia. And things like infections can be implied in that, but we don't always know what it is. In childhood, the commonest age for cancer is the preschool age, under 5s, but it occurs all the way through the age spectrum, and it does vary a little bit by which kind of cancer we're dealing with. So, how do we deal with cancer? Well, in my mind, there are two approaches, really. Of course, we want to give the best possible treatment for the child, to give them the best possible chance of recovery, but recognizing that kind of earthquake that happens when the cancer diagnosis is made, we also want to give the patient and their family the best possible support. And so that's how we think of children's and young people's cancer care: best possible treatment, best possible support. So what actually happens when a child is diagnosed with cancer? Well, usually the child will become unwell at home, and they'll go to their GP or go through the A&E unit and end up being referred to their local children's services, not a specialist service like ours, but the local children's services. But the thing that happens to the child will vary depending on what kind of cancer they have. So, for example, with leukemia, which affects the blood, the common things are bruising or bleeding. or infections, whereas with the solid tumours, the lumpy tumours, is often a lump or a swelling or some other kind of symptoms that lead to the presentation. And they're usually seen then first in their local children's service and then referred on to us in a specialist service, either transferred as an inpatient if they're sick or seen in the outpatient department. And when I first meet patients in the outpatient clinic, what I'm trying to do is establish a rapport with that family and make them feel at ease, help them to trust us as a team, because there's a lot going on for that family at that time, and they're in a very vulnerable situation. We'll arrange the necessary tests to make a diagnosis, to know what kind of cancer they have, and also to know whether there's any signs of spread. So, for example, with leukemia, we'd need to do a bone marrow test, and we'd need to take a sample of the fluid that bathes the brain. But with the kind of solid tumours that I deal with, the sarcomas, we'll probably take a biopsy to send off to the lab, and maybe have to do some scans to work out whether there's any spread. And then once we've got the diagnosis and we know whether there's any spread, we'll then sit down with the family and the patient, of course, and go through the diagnosis, go through what we found, and go through the treatment plan. And I just wanted to slip in, but not discuss in any detail, that as modern science advances really rapidly, part of what we routinely do now is to offer whole genome sequencing or some sort of genetic testing of the tumour, so that we can understand what the genetic changes are in the tumour that might help us understand how it will behave, and even what kinds of treatments might be the best for that child. So we've worked out what's going on, and then we need to get the patient to have the right treatment. And don't worry about this flow sheet here. This is just an example of the kind of roadmap we give families once we know what we're dealing with, to help them visualize what's going to be going on for them through the treatment journey. But really, the right treatment depends on what kind of cancer they have, whether it's spread. Nowadays, we use molecular testing, genetic testing, to help us pinpoint the differences between subgroups of the same cancer, and that can be really important in deciding what treatment plan to give to that child. Importantly, we treat according to standard protocols, so we don't make it up. If a child comes to us with a certain set of diagnosis and stage of spread and so on, then we're using typically now sort of European or international treatment protocols, possibly as part of a clinical trial, on which to treat that patient. And we usually have some idea about the likelihood of success that we can discuss with the family and, if appropriate, with the patient. In children's cancer, the standard treatments are still chemotherapy, surgery, and radiotherapy. We have access to proton beam radiotherapy, which is at University College Hospital in London and in Manchester, so we're fortunate that it's just up the road in central London. And in children, we're now beginning to use immune therapies and some targeted therapies earlier on in treatment. But alongside all the treatment, we need to support the child and the family. So how do we do that? Well, one way we do that is to have great environment to treat the patient in. So these are some pictures from the Royal Marsden. And on the left-hand side, as you look at it, there's a couple of pictures of children in school. So we provide a school so that when they're in hospital, they can still do the normal things that they would do. We provide great facilities. You can see a younger teenager sort of lounging on a couch there with a great TV. We try to have nice, bright facilities. The bottom right is an inpatient facility, and you can see a nice picture on the back wall. So we try to make it a nice environment for the patients. And we try to find fun things to do when they're not having cancer treatment. So great toys to play with. On the right-hand side there, you can see the therapy dog that comes to visit once a week, and the kids absolutely love that, and looks like the mum's enjoying it as well there. And then, probably most importantly, we have a great team. So, all the people that are working in children's cancer centres are experts, the doctors, the nurses, the pharmacists, the play specialists, the physiotherapists, the occupational therapists, the speech and language therapists, the psychologists. They're all there to provide support for the patient and family and provide a support network. There's a cancer charity called Young Lives versus Cancer, which offers emotional support and social care for every family affected by cancer in children and young people. And they're a really integral part of our service, although they're actually charity funded and not NHS funded. And then we also link in with lots of other charities. So, for example, there's something called Make-A-Wish, which provides fulfills wishes, if you like, for children and young people, maybe going on a holiday or meeting their favourite football team or things like that. So there's lots of stuff that goes on around the edges of children's cancer care to try and make things a bit more bearable and to provide fun things and things to look forward to in the midst of what can be a really grueling treatment protocol. Where's treatment given? Well, I apologise, this is a bit small, so you don't need to look at the detail, but what I'll tell you is that in London, there are 2 specialist centres for children's cancer. One is the Royal Marsden, which partners with St George's Hospital, and the other is Great Ormond Street, which partners with University College Hospital, and that's where the proton therapy is. But around the whole of the UK, there are 21 specialist children's cancer centres, and we all work in the same way, that the specialist treatment is given in the cancer centre, and then we work with other hospitals around the region. So you can see on the map there that we have, for us, we're dealing with hospitals in Kent, Surrey, Sussex, South East, South West London, to provide a kind of networked care where some of the care can be delivered closer to home. And actually, alongside actually looking after individual children and their families, this paediatric transformation lead role that is a bit of a mouthful, is a big piece of work that we're going on, trying to support more care to be delivered very high quality way closer to home, so that children can have more chemotherapy, more of their care close to the home, and not have to come into London all of the time for their treatment. Where does research fit in? Well, research is a massive part of what we do in children's cancer, and all that we do now is built on previous research that helps us to understand what the best treatments are. And you may be aware that many children are offered clinical trials when they're first diagnosed. We're typically then comparing the best current known treatment against what we hope would be an improved treatment, either to improve cure rates where the cure rates are not as good as we'd like them to be, or perhaps where the cure rates are very good, to try and reduce the side effects of treatment, to allow those children to not just to survive, but to grow up with as normal, healthier a body and mind as possible. And but alongside the clinical trials, which, as I've already said, are kind of typically these days are international trials, because the number of kids with cancer is small, and in order to answer really important questions about treatment, you need quite big numbers of patients. So you can't do that in one centre, can't even do that in the UK very often. So we now work with European colleagues and sometimes with North American colleagues to try and deliver clinical trials that will answer meaningful questions that are important to not just for us in the research community, but also to our patients and families. But alongside the clinical side, the very rapid advances in science and technology means that we're understanding much more about the genetic changes in cells, what drives the cancer cells. So people like myself, I'm a clinician, I'm not a lab scientist, but I work quite closely with people working in the lab who are trying to understand what causes cancer, what drives it, who are trying out new treatments in the lab we can then bring through into the clinical setting. And so alongside the clinical work we do, we're often taking blood samples, tumour samples that we send off to the lab, so that we've got a kind of continuous bench-to-bedside model where we use the patients' samples from the current patients to try and improve things for patients in the future. And part of what we do at the Marsden is we have a big unit called the Drug Development Unit, which is for children, which is looking at drugs in the early stages of use in children, trying to understand their safety, what doses to use, and then beginning to understand how useful they are for children before they go through into the bigger European clinical trials. Now, this one is a bit, I'm not trying to blind you with science here, but just to explain, this is the current trial that I'm working on, which is called the Frontline and Relapse Rhabdomyosarcoma Study. But the way we run these clinical trials nowadays, they're really quite complex. So this particular clinical trial, we're looking at, you don't worry about the details, but we're looking at patients who are newly diagnosed with rhabdomyosarcoma. We're looking at those for whom it's come back. We're asking chemotherapy questions in Frontline. We're asking radiotherapy questions. We're asking questions about what we call maintenance chemotherapy, which is kind of low-dose continuing chemotherapy. And alongside of that, we're asking questions about X-ray and other kinds of imaging. We're collecting samples for biological studies. And this is a big international trial that's running across 17 different countries at the moment, with 1 or 2 more to open. So the details don't matter, but it's just to give you some sort of flavour of the kind of thing that we're working on. It's not just all what's happening at the Marsden. We're very much linked in with the whole international community. Now then, what if the cancer comes back? Well, usually we can offer more treatment, but it's generally true that the chances of success are diminished if the cancer comes back after first-line treatment. And sometimes we're in the situation of simply trying to control the disease rather than being able to offer a cure. We can still offer our standard of care treatments. There may well be chemotherapy, sometimes surgery or radiotherapy that can be offered. There may be a clinical trial that can be offered, perhaps a sort of more like a standard treatment trial, or perhaps one of our early phase trials that we run in our drug development unit. And we can sometimes get hold of drugs by compassionate access, so drugs where they're interesting, but they're not licensed for use. We can't buy them, we can't use them, we can't prescribe them on the NHS, but the drug company will give them for individual patients. And the kind of therapies we're using then, bottom right is that sort of standard chemotherapy, but and this is a bone marrow transplant, which is needed for some children with leukemia. But as things get more difficult, we're very interested in what we call targeted therapies, so there's a bullseye. So that these are therapies that are designed to interfere with a particular biochemical pathway in the cells. And so if you like, they're smart drugs. They target something very specific rather than chemotherapy, which is much more general. And at the top left there, we're increasingly interested in immune therapies, which can be what we call cellular. They can be antibodies. They can be antibodies that are attached to chemotherapy drugs and then home in on the tumor cells to deliver chemotherapy in a very targeted way. So there's all sorts of new stuff going on, and we can talk more about that later if you have questions. Sometimes cure is no longer possible. Sometimes we can still offer treatment, but obviously we also want to think very carefully about supporting that child and family to live the best quality life they can, even though we know their life is going to be shortened. So we have a great palliative care team. We're linked in with children's hospices, and we're linked in with bereavement follow-up for when patients sadly die, and we do support patients and parents and families beyond death. In terms of late effects of treatment, so sometimes we can cure children. 84% sounds fantastic, but it's not always that easy, because about 60% of survivors of childhood cancer will have some kind of long-term side effect of treatment, and some of these are shown here. So things like it can be an impact on fertility. We can offer fertility preservation these days. There can be impact on hormones, on the bones. Mental health is a really big issue, especially in young people treated for cancer rather than children. There may be effect on organ systems like hearing, heart, lungs. In education can be interrupted. That may not matter so much if you're 5, but if you're 16 and you're doing your GCSEs, that's a really big deal. There may be relationship issues. It often triggers tension in families when a child has cancer because of all the struggles that they have to go through. So, in our treatment, we've always got a mind, not just to improving cure, but also trying to reduce the side effects of treatment so that the children and young people we treat will grow up as healthy, as well, as normal, if you like, as possible going forward. So, in what sense is this doing God's work? And what I'm going to do is really quite personal reflections. This isn't meant to be a theological treatise on how children's cancer fits in with God's kingdom, if you like. But I suppose I just wanted to explain the way I see it, really, which is that we all live in a world that's fallen. It's full of suffering, it's full of sickness, it's full of conflict. The world is not perfect. And in the way I see it, cancer is part of that fallen world. It's not what God designed, but it's the way things are at the moment. But we also have that hope that, God's promise that one day he's going to renew things. He's going to renew heaven, and he's going to renew earth. And the earth will one day be as it was intended to be. And I think at that point, then sickness and suffering will be gone. Right now, we're kind of in the in-between times, aren't we? Because we know God's kingdom broke through. When Jesus came, he started doing extraordinary things through his ministry. In particular, his death, his resurrection was all about God's kingdom breaking through. And he left his spirit for us to kind of work in God's way going forward. But we know that the kingdom is not yet complete. So it's kind of there, but it's now and it's not yet. So what I think about my work is that it's kind of like working with God to demonstrate his kingdom as much as possible in the different aspects of our life. So it can be home, it can be church, it can be family, but it's absolutely about work as well. And in my case, that's about, through the treatment and care of children with cancer. And for me, it's kind of part of whole life worship. We're talking about worship, aren't we, on Sundays at the moment? And encouraged to think about worship as being affecting the whole of our lives, not just what we do on Sunday, but the whole of our lives. And I think life work is worship, both body and mind. And I was reminded about this familiar verse in Romans 12:1 and 2. Therefore I urge you, brothers and sisters, in view of God's mercy, offer your bodies as a living sacrifice, holy and pleasing to God. This is your true and proper worship. Do not be conformed to the pattern of this world, but be transformed by the renewing of your mind. So, I use my body, I use my voice, I use my mind at work. So this has to be part of my worship. And then I'm just going to get even more personal, really, because, well, what does that mean? How does that work out in real life? What does it mean to worship God in my work? And this verse that we'll come to in a minute has been a real kind of guide to me right the way through my work life, I think. The context, Micah is writing to a thoroughly corrupt nation of Israel, and he's calling it to repentance. And the question arises, what kind of sacrifice does God require of the repentant Israel? And the answer comes here. He showed you, O man, what is good. And what does the Lord require of you? To act justly and to love mercy and to walk humbly with your God. So kind of, for me, acting justly, that's kind of being fair, isn't it? It means being fair, full of integrity with the patients and families, with the staff I work with, in the strategic work I do, whether it's regional level, at national level, in the research discussions. Be just, be fair. Love mercy, be kind, be merciful. Again, in all those different contexts, we're to show mercy and not judgment. And be humble. Well, this is a really tricky one, I think. It's easy for us to be arrogant as doctors. We're well educated, we're well paid. It's a high-profile profession. In my particular area, when the patients and families come to us, they're very vulnerable. And there's a power differential. I'm the one with something to offer, and they're the ones who need my help. And this whole issue about humility was really brought home to me. In 2010, I was diagnosed with breast cancer, and then I've had a more recent issue as well. And all of a sudden, instead of being the doctor that's treating the doctor over here that's treating the cancer patient over here, well, I am the cancer doctor and the cancer patient, and the distinction just kind of melts. And honestly, that has been a real struggle, but it's been a real grounding experience as well when I come to my work, because, well, what do I need to do? I need to think about the needs of the patients and families that I work with. So be just, love mercy, be humble. Well, that reminded me then of God himself, really, who in his mercy sent his son Jesus, who humbled himself, died on the cross, and that allows us to be judged as sin-free rather than sinful by our just and merciful Father. So kind of this verse is saying to us, I think, that we need to be like God, to be like Jesus. And then the final thing, of course, is then to walk with your God, to walk with him as well in our everyday lives. So a small verse, but a lot to think about, at least for me. So in practical terms, then, as I've already said, I think the outworking of that is to try and keep the child and the family at the center of all we do in our work life. And that's what this picture is meant to show. There's a lot of noise goes on. There's jostling for power. There's chaos in the NHS at times. Sometimes life's just too busy. But somehow through all of that, we have to keep the focus and make sure the needs of our patients are being met. So that's what I was going to say. I hope there's lots of time for questions, and I'll be very happy to continue the discussion. Thank you very much.
Thanks, Julia. A transformative account, actually, of the inside story of what you do. I'd never been to the Marsden all the years I lived in Cheam, just because we as a family were not affected by cancer. And most of the people I met and worked with and pastored involved with didn't have it either, until this year. And I journeyed with Craig Wilson for the final weeks of his life. I'll never forget the treatment I observed him receiving at the Marsden. And I speak on behalf of all of us, I think, how grateful we are living here to have not just your good self, but also the treatment that the Marsden represents. Another personal level, I'd like to ask you a question, then we'll go to questions. One of the things that I think many of us struggle with is the apparent randomness of it all, and also the different timescales involved. So you get stories of people who've battled with cancer for many years, others succumb in a relatively short space of time. In Craig's case, I was playing golf with him in July. And an extreme example of that, of course, that quite a number of us know about, is Simon Thomas, Blue Peter presenter, Sky Sports presenter. Gemma was diagnosed with acute myeloid leukemia at the beginning of the week, and by the end of the week, she was gone. His book, Love Interrupted, is a very powerful read, and I'm very grateful for Simon. I've been in touch with him this week. He's coming later this year to talk to us about his story. Not just that, his title is Fun, Football and Faith. I had to move it to September, but that's another story. Can you comment on this randomness and the timescales involved in your experience of how this goes on?
Yeah. I think, obviously, cancer is a whole group of different diseases. It's not one disease. And so different cancers behave in different ways. And, sometimes patients will die from the cancer itself, but sometimes things like overwhelming infection can be the problem, so or side effects of treatment as well. So I suppose the whole cancer journey is quite precarious for patients, and obviously it's our job to support people through as best we can. I suppose there isn't an answer, is there, to the question you pose? Why for some people are they cured of their cancer? Why for other people can they have cancer and live for years? Why for other people is it all incredibly quick? And there isn't an answer to that question, I don't think. Not in this world, anyway, Yeah. And but I think as clinicians we recognise the difficulty that people struggle with in that situation, which is why I try to emphasise that it's both the best possible treatment, but also the best possible support that we can give. And I think, speaking from my experience as a clinician, but also my personal experience, I think, it's the love and support of those around you that makes the difference when you have cancer. I mean, the doctors and the nurses, that's all important, and you obviously want your treating team to be as tuned in and as sympathetic and as excellent as possible. But actually, what you really need is your loved ones to come around and to provide that support, and for your faith to be well developed, so that at the point of need, you're not asked. This is what I quite strongly think that you're not trying to grapple with the big questions of life at the point where your life is ebbing away, but you grapple with those big questions. You understand what Jesus offers. You've made your commitment, if you like, and you know where you're heading, and then everything else, in a way, is sort of, we don't know how long our life is, do we? I could fall under a bus tomorrow. I could live for another 30 years. I don't know. Somehow we've got to live in this world in a way that we're prepared that we might not live for much longer, but hoping that we will. It's not really an adequate answer to your question, because I don't think there is an adequate answer.
I knew it was an impossible question.
Thank you.
I'm sorry about that. Questions from anyone here in the group this morning? Anybody want a question? Comment? Oh, we got them coming up. Right, Marguerite.
Sorry, not terribly important question, but you said there's 21 places around the country for treatment, and then you showed a map of the southeast, and there seem to be at least 21 there. So what's the situation in the north and west of the country?
Yeah. So there are 21 specialist children's cancer centres. So in the northwest of the country, Liverpool, so Manchester, Liverpool, and then into Glasgow would be the next one further north. So there's one in Sheffield as well. Leeds, going northeast, is Leeds and Newcastle. So they're the specialist centres like the Marsden that do the really specialist care. And then the map I showed you was the like hospitals like Epsom General or Royal Surrey and Guildford that are not specialist children's cancer centres, but still provide some other network care that we deliver. Yeah.
Sarah.
Hi, I'm just wondering if you've ever experienced signs of the miraculous where a child has gone past the point of no cure but have indeed survived.
Yeah. I knew somebody was going to ask me that question, and I'm not sure. So the answer is not. Well, I find that a difficult question, if I'm honest. As a doctor, most of the time we get a fairly clear idea of the direction of travel, and I've never seen a situation where a child has been in a dire situation and that's been completely transformed, if that makes sense. But I have seen patients that have done better than expected, and I think what I was trying to, I suppose as I was developing my talk, I was trying to think about the fact that that in a way God is doing his work with people like me, so the miraculous can happen, and I believe in that, but it's not what we see in the everyday, because actually we've got a great NHS and we've got great doctors and nurses, and God doesn't need to kind of intervene in a miraculous way for every person that is treated. So again, it's probably not a satisfactory answer to your question, but I think it's quite a difficult one. And also the other part of that question is, well, what is healing anyway? We worry about physical healing, about life being restored, but the most important healing that we have is our spiritual healing through Christ, and being secure in our relationship with God. So, can I? I
think, can I come in, Julia? Not as a theologian particularly, because I'm only an amateur theologian. I'm just a geographer who does colouring in. Our view of the miraculous, and you rightly say, is the in-breaking of God into the circumstances of our lives and the normal order of things. And I think that seeing the work, as I have a GP daughter, seeing the work of doctors as doing God's work is a very direct correlation. God is using the skills of yourself and others. And there is a sense in which that old hymn that some of you may remember, Christ has no hands but our hands to do his work today. Christ has no feet but our feet to walk in his way, and so on. At the same time, we don't want to rule out the possibility. I'll tell a story later if we finish about that. Danger, I think, in church life of having perhaps a very triumphalist view of healing. At the same time, you need to recognise and expect and ask God to increase our faith in these matters.
Yeah. I'll just tell a story, if I may. It was when I was working at Great Ormond Street Hospital. There was a young patient there, had a kidney tumour, he was my patient, and he was probably about 4 or 5. And the family, lovely people, but they were lovely people. They were from a sort of a Pentecostal background. And the child needed to have surgery to remove the tumour. But because the tumour had spread into the glands in the tummy, we also recommended that the child should have radiotherapy. And this family, they believed that God had healed in the surgery, that there was no need for further treatment. They believed God had told them that the child was going to be okay after surgery and nothing more was done. And I couldn't persuade them. And obviously we have statistics about how well children do, and we know how well they do with certain treatments. So you use your kind of scientific knowledge to try and persuade the family. And actually, in that particular instance, he was curable. This patient was curable. And we ended up in a situation that I didn't want, but we ended up having a legal case around what was in the child's best interests. And the court actually decided that radiotherapy was going to be in the child's best interest. But by the time we'd gone through all that process, the tumour had come back in a rather aggressive way, and the child sadly then died. And so I do think it's really hard to get this right. How do we understand faith, and how do we understand healing, and how do we understand conventional medicine? Yeah.
Thank you. Another question? Peter. I keep moving because I'm in the way of the camera.
Yes, we live in a fallen world, but to what extent has research showed that cancer is a 20th/21st century developed illness in humans compared to previous centuries? And is it to do with our lifestyle? Has the research helped to inform us better? So, for example, in 1750, would someone have died of cancer?
Well, I think the answer to the question is yes, but probably not as many people died of cancer in those days as die today. So cancer is not a new phenomenon, but it's much more common now than it was even 50 years ago or 100 years ago. And that is down to lifestyle issues. So I think that all started off in the 50s with Sir Richard Dole looking at the effects of smoking and lung cancer. And it became very clear that tobacco and lung cancer are very closely linked. So we know things like smoking, alcohol, not a little bit of alcohol, but significant amounts of alcohol, obesity, sun exposure for things like melanoma, all these contribute to the risk of cancer, and so many of those things are increasing in our society. So there is, to some extent, a sense in which cancer is, we're not helping ourselves as a society in this area. Also, cancer is a natural consequence of aging because of the genetic changes that accumulate in cells. And so, people live longer these days because medicine is better and keeps people going longer, and in some ways they live, they're better fed and they have healthier lifestyles in some regards. So I think it's quite complicated. I don't think cancer's ever going to be gone this side of heaven or this side of the new creation, but I'm not sure we're helping ourselves either. But I think there's different in children's cancers where we haven't really got evidence that it's those kind of lifestyle things that are impacting on children's cancer. The incidence is increasing a little bit, but we don't know, but not as much as in adults, and we don't know all the reasons why it is in children.
Thank you.
I think you partly answered my question in what Peter asked. Why is it, do you think, that survival rates in Britain are not that good compared with a lot of European countries that are similar type to us?
For adults. I mean, I think for children we're doing reasonably okay. There was some stuff in the news, wasn't there, about cancer outcomes quite recently. I'm not sure I'm an expert on that from the adult perspective. I think things like long waiting times and access to services and things will contribute, although the cancer pathways are supposed to get people to the place of the care they need quite quickly, but they're not working all that well at the moment. In fact, they're not working very well at all at the moment. That may be contributing to things somewhat. I think we have relatively few doctors and hospitals and technology compared to some other Western countries as well. So although we're not bad, we're absolutely, as you say, we're not good, and I think we've fallen away a little bit compared to some of our other European counterparts in recent years. So there's work to do to try and bring that back up again. Yeah.
Julia, can I just ask, when you were setting out on your professional career many years ago, what was it that drew you to oncology, and in particular paediatric oncology?
Yeah, that's a really good question, Lucy. So I kind of, when I was in med school, there were a few things that I enjoyed doing, but paediatrics was one of them. And I think I decided quite early on that I wanted to do children's work for my career. The first job I had, in those days we had to do 2 6-month house jobs. So I did my clinical training in Oxford, and then I did 6 months in Banbury and 6 months in Oxford. And then actually William had a job down in Southampton. So I needed to get a job down in Southampton. I applied for 2 jobs, and the one that came up first was in the children's services. The other one was an adult sort of rotation. And so I ended up doing this job in Southampton. And the very first bit of my rotation was children's cancer, which I'd never really come across before. And I actually really enjoyed it. The other thing I really enjoyed in my training was neonatology, sort of special care baby unit type stuff. And I think they've got some links because they're sort of quite protocol driven, quite research based. Quite high intensity specialties, but neonatal care was a bit too exciting in the middle of the night as you get older. So I think oncology was partly why I chose it. But actually the other thing was that, this may be a bit less conscious, but my mum suffered with Hodgkin's disease when I was a young child. I was 4, my brother was just newly born. And so although I don't remember too much about that, I was kind of aware of cancer from an early age. I was aware that younger adults could suffer with it. I don't think that consciously influenced my choice, but I wonder whether it did a little bit in the end. Yeah.
One more question. What do we got? Yes. Thank you, Michael.
Thank you. I'm not sure how to put this, but focusing on the child, how does the child see its illness? How does it cope with it? I know the child is there to be treated for cancer, and that's the main concern. But about the child's own perception of what's happening to them, how does that affect them?
Yeah, it's a really good question, isn't it? And it depends, of course, on the age of the child. You know, a 2-year-old and a 16-year-old would have quite different level of understanding, and then there's everything else in between. So I think the way, with young children, most of our interaction was with the parents or the carers, and obviously we examine the children and we're prescribing the treatment, and the nurses are doing the practical aspects with that. But very often with young children, we're kind of looking after the parents, and the parents are looking after the child with all the support of the wider team. The child, whereas with older patients, you know, once they're old enough to understand, it's really important that we give them the opportunity to hear about what's going on, that we don't just talk to the mums and dads, that we actually talk to the older patient. And then there are some clinical judgments to make in the 9-10-year-olds, how much you tell them, and sometimes families have strong opinions about what we should and shouldn't say, and sometimes they're quite relaxed and we let the child kind of direct it. So we try to kind of work with every family in terms of the information that we give that's appropriate to the child's age. In terms of the impact on the child, which I think is probably more your question, what's their understanding? A small child will only understand that life's different from normal, and that we might be doing things that they don't like, and they might not be feeling very well. They might be away from their brothers and sisters. They're away from their grandparents if they're in hospital. Those kinds of things. So a child will see it more in the here and now, and what's the difference between what they perceive as normal life and what's going on now. And really young children don't have much existential angst. They're not worried about dying. They're not worried. You can use the word cancer with a small child because they don't know what it means. Whereas as you get older, then the word cancer begins to become associated with life-threatening illness and so on. So older children, we have to be careful about the words we use. But once we start, it's important they do know they have cancer. But we often don't use that word kind of immediately. We try to help them understand they've got a lump and the lump's got a name, and then in due course they'll work out they've got cancer. So I think for all children, they're worried about the impact on their everyday lives, and then their level of understanding about what cancer means kind of increases as they get older. And then there's a whole other thing about what's the implications for the future, which most younger children won't understand at all, but teenagers are interested in fertility, relationships, education, those kinds of things. So we often spend quite a lot of time talking about those things and trying to do what we can to make sure that we mitigate any potential side effects going down the line. Yeah. Does that answer your question a bit? Yeah. Yeah.
I think we need to just wind up now. I'd like to, just before I thank Julia, and we have a little prayer, I'd just like to tell you a story which some of you have heard before, and I had to have permission from the people concerned to tell you these stories. 2 young people in this church, 2 girls, early teens, not the same, not contemporaries. They were some years apart, and in my youth work here, and one was diagnosed with cancer, and the Christian family gathered round, the church family gathered round, and Nicola died at the age of 13, I think, roughly speaking. The other one, another Christian family, and the girl's name was Lucy, and she was critically ill in those days at the Atkinson Morley with some terrible condition and weakening steadily by the hour. And it was a fungal infection around the heart, so it wasn't cancer, but it was something quite serious. And one of her friends who used to live over here said to me, "Ken, we better go and pray for Lucy." So she and I went to the Atkinson Morley, and Lucy was very weak. And we held her hand and we prayed that God would touch her and heal her. I have no discernible gift of healing, I assure you. So we prayed for her and we went home. She woke the next morning and said, "I feel better, I want a pork pie." Now, there is no difference between the environments of those 2 families, their Christian faith, their commitment, their participation in our life here at St. Paul's. In the mystery of God's eternal purposes, it's not helped by 1 or 2 well-meaning people in this church at that time who said to one family, "If you'd had more faith, then she would have been healed." And that was a pastoral disaster. And I'm sure all of us would want not to hold, I'm sure we don't hold that view, but I'm encouraged by that we stand together in this critical and uncertain world as this condition touches so many of us in different ways, to know that the future and the purposes of God are in His hands. And we entrust ourselves to His hands and to the care of people like Julia. Let's give Julia a round of applause, shall we? Thank you.